I'm going to talk about subclavian steal syndrome, and I'm going to leave the carotid disease for another talk because it just would end up taking too long. And I picked this topic because it's a little bit fun, and I also think it's a very underappreciated problem that we have in our vascular patients. So subclavian steal is a condition in which the subclavian artery, the proximal subclavian artery, proximal to the origin of the vertebral artery, narrows or becomes occluded, usually due to atherosclerosis. And the blockage results in the lack of blood flow so it doesn't reach the ipsilateral arm through the subclavian artery, but the arm is usually perfused by having a reversal of blood flow through the ipsilateral vertebral artery. And so that requires a patent circle of Willis from the opposite side. And the condition oftentimes is asymptomatic. If symptoms occur, they're mainly caused by ischemia of the affected arm or posterior neurologic symptoms. They can include limb pain, fatigue, paresthesias, and cold skin. Neurologic symptoms such as presyncope or even syncope may occur, and cerebrovascular lesions may also be present. Stroke, fortunately, is rare. We'll discuss when that may occur. Sometimes patients have this pulsatile tinnitus that also can be a symptom of this. And the characteristic diagnostic sign is a discrepancy in the blood pressure between the two arms, usually of more than 15 millimeters of mercury. Imaging, for example, ultrasound can identify a reversal of blood flow in the vertebral artery, as well as the stenosis in the subclavian artery, and that usually confirms the diagnosis. And then treatment is usually endovascular or operative bypass grafting. We'll go over some examples of those. So the workup for this type of entity, there's usually a history of either lightheadedness, dizziness, or occasionally presyncope or syncope, especially with the use of the arm. And we always ask, is the patient right-handed or left-handed? If it's the non-dominant extremity, it may change how we're going to treat the patient. There's usually an absence of hard neurologic abnormalities. So patients who have a discrete paresthesia or weakness or documented nerve conduction abnormality probably have some other entity that's causing their symptoms. So it's important to rule out some type of neurologic abnormality. We check blood pressure in both arms, and if you can't get it with the cuff or the automatic machine that we typically use, you need to learn how to use a Doppler to obtain the blood pressure. And then occasionally we use provocative maneuvers if we think thoracic outlet syndrome may be suspected, and possibly nerve conduction studies as well. The basic test is a duplex ultrasound of the carotid and vertebral arteries as well as subclavian arteries. And in my opinion, all of those vessels should be checked with every carotid artery ultrasound study that's performed. In our lab, our techs always check the vertebral and the subclavian arteries. They typically will not do that in the hospital setting. So if you want that checked, you may have to order two different studies. And then for the symptomatic patient, we'll either do a CTA or an arteriogram for a complete diagnostic picture. So again, this is just a reminder, always check blood pressure in both arms. Every single patient that's seen in our office gets their blood pressure checked in both arms. And just a little caveat to a couple of stories. I had a patient I was doing an aortic operation on one time. I finished doing the procedure and took the clamps off, and the aortic pulsation was absolutely bounding. And it was bleeding from the suture line, and I look up at the monitor and the blood pressure is 70, and I asked the CRNA who was there, I said, what's the blood pressure done? He's like, I'm giving pressors as much as I can to get the blood pressure up. And I said, this blood pressure is like 250. What are you talking about? And I said, check the blood pressure in the opposite arm. In the opposite arm, the blood pressure is 250. And this patient had an undiagnosed subclavian artery occlusion that nobody knew about. And I was a little bit embarrassed as well. And I've had that happen several times. So it's important to know before you get to the operating room or before you put an art line in somebody that they have normal blood pressure in that arm. So this is, on the left is the basic the basic anatomy here, the left ventricle arises with 3 branches off the aortic arch. The right subclavian, the right common carotid artery, the right vertebral artery here, the left common carotid artery here, the left vertebral artery, and then the subclavian. So in this situation, we have a stenosis or occlusion in the left proximal subclavian artery. And typically what happens is you'll see blood flow go up the contralateral vertebral artery and then back down in a retrograde manner to supply blood flow to the arm. It's very obvious when you do some of these diagnostic studies. Yeah, so you can see on this slide, you might have to play it a couple of times. You see the late filling of the left vertebral artery here that's supplying the left subclavian artery from the occlusion or a tight stenosis there. On ultrasound, this is an ultrasound of the subclavian artery, and typically what we'll see is a real high peak systolic velocity here. In this case, it's 363. You know, anything over 200 to 250 would typically be considered an abnormal velocity. So it's fairly easy unless the patient's really big or the stenosis is real proximal. Usually the technicians can see this. And then when they insonate the vertebral artery, they can actually see retrograde flow in the vertebral artery. So we always check vertebral artery. You don't necessarily look at the velocities so much with the vertebral artery, but we're looking for either antegrade or retrograde flow. And typically for a subclavian steal, these patients are going to have high velocities in the subclavian artery and retrograde flow in the vertebral. So these are kind of variations on the anatomy of the aortic arch. This upper left one is the typical with 3 branches, the left vertebral artery here and the left subclavian artery here. This is a patient with a common trunk with the left common carotid artery coming off of the innominate, and that's fairly typical. We see that. This is another variation of the same thing. We see that fairly common as well. This common trunk where there's only one trunk coming off of the aortic arch is very rare. So etiology of subclavian artery disease is multifactorial, but more than 80% of these are atherosclerotic. On the coast, you may see some Takayasu arteritis. You could have fibromuscular dysplasia or giant cell arteritis. I've never seen that myself as an etiology for subclavian stenosis. Radiation-induced vascular injury does occur periodically with mantle radiation to the chest. And it can be confused with thoracic outlet syndrome, so that's another etiology that you need to kind of rule out. And the neurofibromatosis is another etiology. So the indications for revascularization are typically symptomatic ischemia of the posterior fossa. These patients may be getting lightheaded or feel like they're going to pass out, especially when they're using their ipsilateral arm. If they have this symptomatic subclavian steal, if they have disabling upper extremity claudication, especially if they have to use that arm for their job or occupation. And then also preservation of flow to the left or the right internal mammary artery. So this is a situation where maybe a patient's going to need coronary bypass grafting, and typically they like to use the left or the right internal mammary artery for one of the bypass grafts. And if there's a subclavian stenosis or occlusion there, that's going to limit the flow through that graft. Similarly, postoperatively after a CABG, if the patient has a subclavian stenosis, the flow through that vessel is going to be limited. We would want to make sure we have preservation of inflow to, say, an axillobifemoral bypass graft or a dialysis conduit. And occasionally patients can get embolization to the fingers. We'll talk about that a little bit. Sometimes inability to obtain a blood pressure, like I mentioned, may be an indication to revascularize that. And then thromboembolus to the cerebral supply. So again, this is an example of what we would consider a coronary subclavian steal syndrome. So you have a bypass graft from the left internal mammary artery to the LAD and an occlusion here. And this actually shows retrograde flow in the Lima bypass graft, although I don't think that's very common, but it certainly can be diminished flow through that. And patient could have a major cardiac event from that. So evidence of coronary subclavian steel. This is just an image of the Lima bypass graft that's sewn to the LAD here, the tight stenosis in the subclavian artery, and then you put the stent in there, and now you can see antegrade flow in the Lima. If the artery is occluded and the stent is not possible, we typically would treat that with a carotid subclavian bypass graft here. The flow is normal in the common carotid artery. You can put a bypass graft in here, resupply the subclavian artery. Then you're going to have antegrade flow in the vertebral and the Lima bypass graft. Just another example of the same thing. The anatomy here, usually the Lima is distal to the bypass graft, but there can be variations on this theme. But that's typically what the graft would look like. These carotid subclavian bypass grafts are actually fairly short. They're only about 5 centimeters length, and they work very well. Just an example here of what the bypass graft would look like. It's sewn here to the common carotid artery and here to the subclavian artery. And then on angiogram, this would be the bypass graft here from the left common carotid artery here to the subclavian with the proximal occluded subclavian artery. Pulsatile tendon, this example, a patient with a tight stenosis or occlusion here. And what you don't see is that actually it's this retrograde flow here in the vessel. And then after you put a stent in, everything is antegrade, and sometimes those symptoms will resolve. So treatment options for these various subclavian lesions. The first one here is just a simple, straightforward angioplasty and stent. Here's an example of a carotid subclavian bypass graft, which is what we previously talked about. You might think is if you put a bypass graft in here, is it going to steal blood from the carotid artery? But it does not happen. Actually, it will. The blood flow to the cerebral system will be maintained, and actually then you'll have antegrade flow up the vertebral artery. This is kind of an unusual situation where you might do an axillary bypass graft. That would only be in a situation where the left carotid artery is either occluded or not accessible. And then here is a carotid subclavian transposition where you actually, instead of using a bypass graft, you can ligate the proximal subclavian artery and swing it up and sew it directly into the common carotid artery. I've only done that a few times. It's a little bit difficult to get that far proximal on the subclavian artery, and the anatomy is such that you risk sometimes some injuries to some other structures. So again, just a picture of this atherosclerotic plaque with antegrade flow on the right vertebral artery through the circle of Willis here and then back down through the retrograde vertebral artery. So just to switch gears a little bit, the subclavian steel is typically most of the time found on the left side because the left subclavian artery is longer than the right. But we certainly do have situations where we have a nominate artery stenosis on the right side. To have just a subclavian stenosis on the right side, there's a very short segment here between the innominate and the vertebral artery. Although you can have lesions here, most of the time we see this innominate artery stenosis. And in those situations, you can have embolic phenomenon that can actually go to the ipsilateral or even the contralateral side. You may have antegrade flow up this side and then retrograde flow down the right vertebral artery to actually supply the right carotid artery in a situation where that vessel may be even occluded. So here's an example of an innominate artery occlusion. This patient had aching in her arm and periodic cerebral symptoms. She's 50 years old, has this occlusion in the innominate artery. And this is a CT scan, but on the arteriogram, you could actually see this retrograde flow in the vertebral artery that was filling both the subclavian and the carotid artery on that side. So in that situation, you do this kind of crazy bypass graft. In this situation, we did a carotid bypass graft. So there's a previous endarterectomy on the left carotid artery with a patch. and then we do a bypass graft from the left carotid artery to the right carotid artery, and now you'll have antegrade flow up the ipsilateral carotid artery. This is actually a fairly straightforward procedure. You tunnel the graft actually behind the pharynx, behind the esophagus, right in front of the prevertebral fascia. It ends up being a fairly short bypass graft, only 4 to 5 centimeters in length, and it tends to work very well. Occasionally, if you're not careful, the patient can, when they swallow a large bolus of food, they might feel it catch a little bit in their esophagus, but generally they don't have any symptoms from that. Just another example of kind of the close-up of the anastomosis here on both sides in the occluded innominate artery here. So again, a symptomatic patient with this left subclavian stenosis here. Stenosis again with the retrograde flow in the vertebral artery late. So again, the anatomy here, the flow is going up this side, back down this side to fill this left subclavian artery. Just an example of where it's at later on in the image. And that's another, if you can play that video too. And it's a very short video, but if you notice when you inject a little contrast here, it starts to go up the vertebral, but then it comes right back down to fill the subclavian artery. So in that situation, even though you can't maybe say exactly what the degree of stenosis is in the subclavian artery, but you know it's significant because there's retrograde flow. Now, in these situations where the stenosis may be fairly close to the origin of the vertebral artery, we have to kind of be very careful. If you're going to stent this, you don't want to stent across the vertebral artery because then you certainly can end up with a stroke that way. So we change the angles on the C-arm to get the optimum angle and then do accurate measurements with a variety of methods to make sure that we get the stent the exact size and diameter that we want. Deploy these very carefully, very slowly, and make sure that we cover the lesion adequately, but we don't cover the vertebral artery. If there's any concern about covering the vertebral artery, then surgical bypass is a better option. And this is post-stent. Is that a video? It might be a video. Yeah. So now you can see there's antegrade flow in the vertebral artery on that side. And just a same picture of the same thing. So this just shows a successful stent here in the subclavian artery, patent vertebral artery with antegrade flow. Now, there's a couple of different ways to stent these. Typically, we like to go from the femoral location. The only problem with that is it takes a long sheath, usually a 6 or 7 French sheath, depending on what type of stent, what size stent you want to put in. There is a little bit of concern if there's spillage of the plaque into the aortic arch. Manipulating through here could potentially disrupt some plaque while you're putting the stent. But typically for a stenosis that's not pre-occlusive, we can usually stent it by coming up through the groin and get a nice stent here. We like the stent to extend into the arch 1 to 2 millimeters to make sure that we cover the whole lesion, but we don't want it sticking way out into the arch. And similarly, we don't want it to be covering the vertebral artery origin. If we're concerned about not being able to stent it from the femoral location, we can access the brachial artery here with a shorter sheath. It's easy enough to get the wire to come through here, and then we can place a stent from the brachial artery as well. Typically, we can do that with a 6 French sheath, and similar to the cardiologists who are doing a lot of radial artery access, nowadays you can even access the radial artery to do this type of work if you need to. Here's a patient that had a tight stenosis and was having some microemboli to his finger. In this situation, we were able to put a stent in the artery here. And then 2 months later, with the artery widely patent, the finger heals up. So that's just a rare situation of an embolic problem. So treatment of subclavian artery occlusions, if you're not able to cross the lesion, or if the lesion is too close to the vertebral artery, is typically done with the carotid subclavian bypass graft. Here's an example of an occluded artery here. Potentially you could try and do a retrograde access and stent it, but if you try and you can't do that, or if it's too close to the vertebral artery, then you need to do the bypass. So this is some of the anatomy here. We have an incision above the clavicle, and this is the subclavian artery. This would be the left side, and this muscle here is the anterior scalene muscle, and this is an important structure here that you have to be very careful. This is the phrenic nerve. It sits right on top of the anterior scalene muscle, and you want to protect that, because if not, the patient's ipsilateral diaphragm is not going to work. It's not a real big nerve, but it should be protected. You can probably do this operation without dividing the anterior scalene, but I typically divide the anterior scalene muscle because it just gives you a whole lot better exposure of the subclavian artery for the bypass graft. It's a similar exposure to what you might do for thoracic outlet syndrome, but not quite as extensive. And then this would be the more medial side of the dissection. This is the common carotid artery here, the jugular vein here, and this is another important structure to note. This is the thoracic duct that's draining lymph from the head and neck region, and if you cut that, you're going to have lymphatic fluid all over the place, and then this thing is difficult to chase. Sometimes it retracts down into the chest. So typically we just ligate that if it's in the field of view. This would be the completed bypass graft. This is the common carotid artery anastomosis here. The jugular vein, we typically, I usually use a little aortic punch and make a little opening here in the artery. And then the jugular vein is here, so we put the graft behind the jugular vein, leave the clavicular head or the sternal head of the sternocleidomastoid muscle intact, and then the distal anastomosis is here. And then on an arteriogram, this would be what you would see here with previously occluded subclavian artery. We're going to have to come back and fix that carotid stenosis later, I think. The results of carotid subclavian bypass grafting are really quite good. If you look at just 5-year follow-up, you have about 87% primary patency rate, and then about 95% secondary patency rate at 5 years. So these bypasses work a long time. I think in my career I might have redone one or two, but it's pretty rare that one of these will go down. So here's another example of an innominate artery stent occlusion. So this patient had a stent here in the innominate artery that occluded. There is a left common carotid stent here. This was only a 55-year-old woman, and there's a little stenosis in the carotid artery, but the main problem was the occluded innominate artery. Again, she was very symptomatic with this. You can see there was retrograde flow in the common carotid artery, and then the flow was coming this way, back up the subclavian artery. This is the occluded innominate artery. You really couldn't see intracerebral flow because there was so little flow actually going up this artery. So another option is to approach this directly and just do an open chest procedure. So this is a sternotomy, this is the heart, this is the aorta, and we've put a loop around the proximal innominate artery where it's occluded. And up here, we've dissected out the common carotid artery and the subclavian artery. The vessel is patent there. So you can see it's a fairly short segment that's occluded. The innominate vein comes right across the artery right here, so that's easy enough to manipulate and move that out of the way. And this patient's 55 years old, but look at her lungs. You know, that's typical heavy smoking. So then this is a bypass graft. We just do a side-biting clamp on the ascending aorta, put an 8mm Dacron graft to the aorta, and then the distal end of it is sewn to the distal innominate artery, just proximal to the bifurcation of the carotid and subclavian arteries. And just an up close version of the anastomosis here, and also up here at the distal end. This is the nominate vein. It's collapsed in this situation. You could tunnel the graft in front of or behind the innominate vein. It really doesn't matter. And then a CTA later just shows the patent bypass graft here, now with antegrade flow in the carotid artery. And then here's another example where the bypass graft is right here. And then finally, just one other indication for a carotid subclavian bypass graft would be this patient. It was an 80-year-old man with an aortic aneurysm in the arch. He had the left common carotid artery in this situation came off of the arch or the innominate as a common trunk. The subclavian artery had to be covered because we put an aortic endograft in the arch to seal his aneurysm, and then did a carotid subclavian bypass graft to reperfuse the arm. So just another example of how that bypass graft can be utilized. Incidental note is that this right carotid stenosis is still going to need to be treated. So that's all I have. Thank you very much. I'll take any questions if you have any.
Thank you, Dr. Bays. That was an excellent talk and overview of subclavian artery stenosis. And so I had two questions. The first was, in patients that are to undergo a carotid subclavian bypass, what's your algorithm in dealing with existing carotid disease? Would you fix the carotid first usually, and then maybe bring them back and do the carotid subclavian bypass, or would you do it irrespective?
Yeah, that's a good question. If it's the ipsilateral carotid artery, I will do this all as a combined operation. So I've done it both ways. I've done a carotid endarterectomy, and then I've sewn the bypass graft onto the endarterectomy site. It ends up being a fairly long anastomosis sometimes, but it serves as a patch. The only caveat is you have to be a little careful because the graft can kink if you're not careful. So if the anastomosis is going to be really long, then I might just patch it and then do the carotid subclavian to the common carotid lower in the neck. But I'll typically treat both of those at the same time.
And then my second question is, what's the role in stenting, would you say, in today's day, through a retrograde, either cut down on the carotid and a retrograde stenting? Do you see that as a viable option, or would you kind of just go ahead with an open chest operation?
No, I think stenting is a viable option, but again, it has to be done very carefully because you don't want to embolize the plaque. You can do it both from the groin. I've done it from the arm. I don't think I've done any from an ipsilateral carotid approach in a retrograde manner. I treat proximal common carotid stenoses that way, but typically you would come from the arm. But again, it kind of depends on how close that stenosis is to the origin of the common carotid artery, because just like the vertebral artery, you don't want to cover the common carotid artery with a stent. Even if it's not a covered stent, you still could disrupt the flow to the carotid artery. So that would be the caveat, is it needs to be a proximal stenosis.
And is your preference utilizing covered stents for your subclavian work?
I typically don't.
Okay.
No, I guess if you had a really high-risk patient that you were concerned that potentially could perforate, but I would say 95% of the ones I've done are just bare metal stents, and they work very well. I rarely have them come back with restenosis.
Mm-hmm. And I think Dr. Bays mentioned a very good point, and I've been very lucky with this, is for subclavian artery stenosis, I will actually just cannulate through a brachial access, get through, then snare it and have a floss through the groin, so you don't have to worry about it. But both techniques definitely do work. Andy, any questions or comments?
For those of you who couldn't hear, Dr. Kazmers was mentioning he comes from the arm and does it in a retrograde manner, most of it. From the carotid? Yeah.
For the nominal carotid, because you're protected. I mean, you can flush your artery through the sheath so that you're not at risk of stroke, and you have really good control
But do you do that with an open technique, or do you do that percutaneous? So you,
I'll do it open.
so you still have to make a little incision and have some anesthetic on board. So that's the only downside to doing that.
Having a patient still is a good thing. I mean, I don't mind an anesthetic when I'm really concerned about my precise stent location.
Sure.
I think also from a technique standpoint, obviously the length of the graft is important. I remember having a patient who was a little tight, and she had she could hear her, kind of the heartbeat through tinnitus almost, through the graft going, the subclavian graft going through, and so having that lie just posterior off the internal jugular vein and laying down is good. I typically don't take the anterior scalene. I kind of leave it unless I'm doing a thoracic outlet, whatnot. What's your experience in that?
I hate carotid subclavian bypasses. I think that they stay patent, but in my experience, if you follow them with Doppler, they very frequently restenose over time. I think that the old data that says 95% 5-year patency, I think is not based on anything other than clinical assessment, because usually these restenoses are clinically silent. So I'll just about do anything to avoid a carotid subclavian.
Well, the data says that obviously carotid transposition probably has a better patency, but as Dr. Bays said, not an easy
I
operation.
think that operation is scary.
Yeah.
I mean, if you lose control of the proximal subclavian,
Right.
you're really in trouble.
What are your techniques specifically to get proximal control? I mean, do you do anything different? Would you consider a wire and a plug, kind of staging it and then doing the transposition, or you just use a side biting clamp and hope for the best?
Well, I wrote a paper on this years and years ago about ascending aortic grafts, and I don't think I've done one in over 10 years. I mean, I'm doing them endoluminally.
How about you, Ron?
Well, they're not common. They're pretty rare. I mean, in a situation like this, you got a young patient. I wouldn't do it in an 80-year-old.
Mm-hmm.
I would try and find some extra anatomic way of doing it.
Mm-hmm.
But I do agree with you. We do see elevated velocities on follow-up ultrasounds, but I can tell you on less than one hand the number of times I've had to re-intervene on them. Occasionally you can angioplasty and anastomosis, but they don't come back symptomatic or occluded. So rarely do we ever have to do anything with them.
So what is your follow-up on them? Do you survey them at all with ultrasound?
I survey everybody with ultrasound.
Okay.
So yeah, we'll check them at 3 months and then at least yearly thereafter. And we have good follow-up. Most of those patients will follow up.
So I think for the primary care physicians here, I mean, I know these are maybe a little bit out there, but patients that have claudication or pain in their arm, or they have, as Dr. Bays said, posterior vault circulation issues in terms of ataxia or discombobulation with ambulation or utilizing the ipsilateral arm, are really pathognomonic for this entity, especially if they have peripheral vascular disease. And I know Dr. Azad had a patient recently who needed a CABG but had a very high-grade stenosis in the proximal subclavian, which I don't think he was able to get through the lesion. And so the question is, one of the thoughts I was, well, do you, do a carotid subclavian bypass prior to the CABG and then let the cardiac surgeon do their CABG, or do you let them just do a free Lima graft off somewhere else, and that's what they actually ended up doing. Any thoughts how you guys would have done things differently?
Yeah, I agree. You would probably try a retrograde approach if you can't get through an antegrade, but I don't think I would put the patient through
Two
a
operations.
carotid subclavian
Yeah.
bypass if they really needed
Yeah.
the cardiac bypass. I think that's a high-risk situation.
Mm-hmm.
I have an odd question. Do you ever do a subclavian reconstruction just so you can measure blood pressure? If you got someone with bilateral subclavian disease, bilateral lower extremity disease, you have no idea what their core aortic pressure is.
Yeah, and that I have had a few patients like that where you can't get a blood pressure in either arm or in either leg. And if you can treat one side safely, then I think it's reasonable to do that, because you think of all the treatment and workup that the patient is going to have in the rest of their lifetime. You have to be able to check their blood pressure somehow in one of the extremities. So
It's
either
a dilemma, and I don't hear anyone talk
Well, that's, yeah, because it's not a subject that we typically, would present. But, yeah, I've had 3 or 4 over the years where you just can't get any blood pressure anywhere. And so if you can revascularize one of the extremities, somehow I would do that.
That's actually a really important point in that I can't tell you how many times I see patients that have differing blood pressures between their right and left arm. In our practice too, every single patient gets a right upper extremity and left upper extremity pressure. What is considered an issue is if there's usually a 20-point differential. Then we start looking and start asking questions about a patient's symptoms. I mean, is that what you do? Do you use 20 points too?
Yeah, and a number of these patients will have significant carotid stenosis as well that you would not have otherwise uncovered.
So something to think about in primary care, just to get sometimes for patients who have PAD to get bilateral upper extremity blood pressures. If there's asymptomatic, if they have no symptoms, then there's obviously no indication to treat. But it is something good to know. A lot of times we may be treating the lower blood pressure, thinking that that's what we're looking for when the contralateral arm is actually the true pressure, and I see that as well.